Hello guys, welcome everyone. Give me a thumbs up if I'm live and audible to you all of you clearly. So today we're going to talk about the stroke management. We have done an earlier session where we have covered the basics of stroke, and today we will take only 20 minutes to understand how to manage a case of stroke and mostly get the MCQs on stroke right. Okay. So give me a thumbs up. I'm waiting to hear from you. Okay, well, it appears that I'm live and audible. So we'll start with that. Before we get into the stroke management, two basic questions about the previous session that gives me an idea that you're attentive and listening to what we're covering. And then I will start with the topic. Okay, so here's the question number one. Which of the following is the most common risk factor for stroke? Good evening, Olivery Nucleus and Nuseba. Which of the following is the most common risk factor for ischemic stroke? We have learned about the classification of the stroke in the previous session, and we know that we divide them into hemorrhagic and ischemic. And then among the risk factors that are there for stroke, what is the most common? I think most of us know the answer pretty clear, and that is going to be hypertension, right? Hypertension is the most common risk factor for stroke. Sutapa, good evening. Oliver Nucleus, good evening. So hypertension is the most common risk factor for stroke. I have given you a brief about why hypertension becomes a risk factor for ischemic stroke as well. Hemorrhagic stroke, we understand blood vessel can rupture and bleed. But ischemic stroke, because when blood pressure increases, there is increased lateral pressure on the wall of the vessel. And because of that, there is possibility of endothelial injury. Couple that with existing atheromatous plaques and the endothelial injury, the risk of developing a clot increases. And that is why we can get the ischemic stroke as well. Okay, so this is the second question. Following sign is useful for early recognition of stroke. This sign is known as. What are we trying to demonstrate here? We're basically trying to identify subtle weakness of one side of the body in comparison to other. And we call this sign as pronator drift sign, right? We recognize it as the earliest sign of pyramidal tract damage. We call it as pronator drift sign. And there is a name given to that. And what should be the answer? Corrigan sign refers to dancing carotids, which we see in patients with aortic regurgitation or any condition where there is wide pulse pressure. Pronator drift sign is also called as Barry's sign. Barry's sign. So that should be the answer for this question. This is a potential image-based question, and I want you to be familiar with that. Pronator drift sign is also called as Barry's sign. It is the earliest sign of pyramidal tract damage. So when we spoke about early recognition of stroke, we spoke about two things. One, the B fast algorithm for early recognition of stroke by the layman, and the second one was the pronator drift or Barry sign for early recognition of stroke by the medical professionals. Okay, so with that background, we will now start talking about the management of ischemic stroke. First thing is, what are the goals of treatment of ischemic stroke? If there is an infarcted brain tissue, can I get it back to normalcy? If some part of the brain, polyuria is fine. So if there is some part of brain which is infarcted, can it be corrected to normalcy? The answer is no, right? Because neurons do not have great regeneration capabilities. Infarcted tissue is gone. Mobius has nothing to do with the strokes. So infarcted tissue is gone. So then what are we trying to treat? What are we trying to treat when we have a patient with stroke? So in the previous class, we learned that when we have stroke, so let me say that this is one blood vessel, okay, and I have created some critical occlusion of this blood vessel. Because of that, the blood flow through this blood vessel has decreased significantly, and this is the area that this particular blood vessel was supplying. A whole of this area is not going to die once for all, right? So you will have some portion which has become infarcted, and the remaining area has stopped functioning, but it is still alive. That portion we call as penumbra or ischemic penumbra. Now, can I recover the infarcted tissue? No, it is gone, right? Can I save this penumbra tissue? Yes. Now, when I see the patient, his inabilities or loss of function is because of whole of this area. The area which is infarcted is not working. The area which is ischemic but not yet dead is also not working. So whatever deficit I am seeing in a patient is because of this. This much is non-recoverable, but remaining penumbra is recoverable. So if I recover the penumbra and I make it functional, make it normal, can I improve the can I expect the improvement in the weakness? Absolutely yes, because the weakness I see is combination of infarcted area as well as the penumbra. I cannot get back the infarcted area, but the penumbra I can get back. So if I ask you what is the goals of treatment, it is to salvage ischemic penumbra. And when I salvage the ischemic penumbra, the outcome of this is I can expect improvement in patients' disabilities, or thus I can say there is possibility of disability limitation. So main goal of treatment is to limit the disabilities by saving as much as brain tissue that we can save. Second goal is to reduce the mortality. There is possibility of death in patients with stroke, so we have to try to reduce the death risk. And the third thing is because patients who have stroke already have the risk factor. Simply out of the blue, someone is not going to get stroke. They may be hypertensive, diabetic, dyslipidemic, or they may be going through atrial fibrillation. So there are risk factors. So there is every possibility that the stroke that has happened today in one particular blood vessel may not affect another blood vessel in future. So we have to also reduce the future occurrence of stroke. In that case, we call it as secondary prevention. Secondary prevention. So these are all our goals of treatment. Number one, salvage the ischemic penumbra. This is the main goal of our acute treatment of stroke. And then we have to think of secondary prevention. Mortality reduction is mainly about preventing the complications, like patients who are going through stroke are at risk of developing aspiration. That is why when someone is going through stroke, when their GCS is low, we need to put them on ventilator or intubate and prevent the aspiration. They will be bedridden for prolonged period of time, so they are at risk of developing deep vein thrombosis. From there, they can develop an embolism, pulmonary embolism, and die. We might have to give them DVT prophylaxis. Third, because they are prolonged time they're spending in the bed, they may develop bed sores, they can get infected, they can develop septicemia and die out of that. So you have to take steps to prevent the bed sores. Those are all indirect ways to reduce the mortality. Apart from that, there are some direct complications of the stroke. As a result of ischemia, there can be development of cerebral edema. Cerebral edema increases the intracranial tension, and because of that, there is a possibility of brainstem herniation and death. So, if there is evidence of significant raised ICT, we might have to give them mannitol or other anti-edema measures. These are all steps that we take to reduce the mortality. They are general steps. Any patient who is bedridden, we take those steps of DVT prophylaxis and all. Any patient who has cerebral edema, regardless of what is the cause, whether it is ischemic, whether it is hemorrhagic stroke, or whether there is a brain tumor or meningitis, we take the same steps. So we'll focus more on the specific treatment related to salvaging the ischemic penumbra and the secondary prevention. Okay. Now, if I have to save this ischemic penumbra, what should I do? What is the main problem? The main problem is there is a block in your blood vessel. So blood flow through the arteries is reduced. Some part of your brain supplied by that artery is dead. Some part is not working, but it is still possible to save this part. And this is what we're trying to save. So simple solution is open the block. So if anybody asks you what is the mainstay of treatment of ischemic stroke, the mainstay of treatment of ischemic stroke will be revascularization or opening a blocked blood vessel. Revascularization or opening the blocked blood vessel. Same thing applies to myocardial infarction, right? When someone has an MI, how do we treat? Open the blocked blood vessel, either by giving drugs to dissolve the clot or putting a wire and removing the clot. So when you put a wire and remove the clot, we call it as angioplasty. And when you give the drug to dissolve the clot, we call it as thrombolysis. So in MI, what is the best treatment? Is it angioplasty or thrombolysis? So Tapasamantha, penumbra refers to, see, like one blood vessel, let me say, is supplying to 4 square centimeter area. That is the area that the blood vessel is supplying. When blood flow reduces, some part of it becomes infarcted. Surrounding area, because it is not getting blood supply, it stops functioning. So when I see the patient, whole of this area is not working. But out of that, only some part is dead, some part is still alive. So this alive part, which is not working because of reduced blood supply, but not dead yet, we call it as penumbra. We can save that part. Infarct is gone, we can't save it. Yes, for myocardial infarction, best treatment is putting a wire into the clot, into the blood vessel where there is clot and removing it, or angioplasty. Angioplasty is the best treatment. Now, can we do angioplasty for a patient with stroke? Can we do angioplasty for a patient with stroke? Can we do it? Well, I'd asked a very similar question during my MBBS to one of my senior resident. Like, sir, we do angioplasty for MI, but why don't we do it for stroke? And unfortunately, I was kicked out from the ward for asking weird question. But times have changed and technology has advanced, and we have similar possibility for the blood vessels in the brain also. Only difference is we don't call it as angioplasty. Okay, so therefore, what is angioplasty is, let me say that this is a blood vessel which has a block. So in angioplasty, we pass a wire. There are different mechanisms to retrieve this clot, right? We can pass a wire and pull this clot, or we can use sound energy to break this clot, and we clear the clot. After we clear the clot, this procedure is called as angioplasty. And to make sure that the artery doesn't get affected with another clot there, we put a small mesh called as stent. So angioplasty plus stenting is the current standard of treatment for a patient with myocardial infarction. Now, in today's world, we have similar possibility for a patient with block in the blood vessels going to the brain. Only thing is we don't call it as angioplasty, but rather we call it as mechanical thrombectomy. When you give drugs and dissolve the clot, that is thrombolysis. When I put a wire and retrieve the clot, mechanically I'm pulling it or retrieving it, we will call it as mechanical thrombectomy. So there are two options now for revascularization. One option will be called as mechanical thrombectomy, and the second option will be called as thrombolysis. Can you name some drugs that can be used to dissolve the clot? What drugs can be used to dissolve the clot? What are called as thrombolytic agents? Here also, the best treatment is mechanical thrombectomy, just like how angioplasty is the best treatment for MI, especially the ST elevation MI. Similarly, for a patient with ischemic stroke, if all goes well, the best treatment is mechanical thrombectomy. But in patients with stroke, there are some steps involved in making a decision कि thrombolysis करें या mechanical thrombectomy करें. We have to learn today how to make that choice. What are we going for by understanding indications and contraindications for both of these procedures. Right, altiplase, tenecteplase, retiplase, right? What is their mechanism of action? Normally, when we make a clot, right, basically clot has a platelet plug, and then the platelet plug is reinforced by fibrin, right? So when we create fibrin, we have to activate fibrinogen to fibrin, and the steps involved in this is our coagulation cascade. Normally, when a clot is formed in the body, after its job is done, this fibrin clot needs to be dissolved. So how do we dissolve? This fibrin gets broken down by an enzyme called as plasmin, and this plasmin exists in our body in an inactive form called as plasminogen. So when we have to break a clot inside the body naturally, like whenever a clot job is done, it no longer needs to be there. To clear it, we have to convert plasminogen to plasmin by an enzyme called as tissue plasminogen activator. It activates the plasminogen to plasmin. Plasmin breaks the fibrin into fibrin degradation products or FDPs. Okay, so now what this altiplase, tenecteplase, they're all nothing but TPA analogs. They behave like tissue plasminogen activator. They activate normal existing plasminogen to plasmin. This plasmin will break down the clot, right? So for thrombolysis, those drugs will be considered as examples, right? What are recombinant tissue plasminogen activator, altiplase or retiplase, and then we have also drugs like tenecteplase, retiplase or tenecteplase. Out of these, only one drug is US FDA approved as of now for thrombolysis, and that is tenecteplase. So if you have to name only one drug that examiner is asking, then it should be tenecteplase. If he just goes on asking about all the drugs, then you can start with recombinant tissue plasminogen activator, alteplase, reteplase, tenecteplase, and whatever other names you come across in your pharmacology. Okay. Now, what I have to learn today is how to make a choice whether I should be going for mechanical thrombectomy or thrombolysis. Obviously, mechanical thrombectomy is superior to thrombolysis, but both of them have their own indications and contraindications. So, in any question, we have to identify whether patient fits into the indications or contraindications for both or one. Whichever he fits into, that is how we will be taking a step. So, first, we will understand mechanical thrombectomy. This is a procedure we mechanically put a wire into the blood vessel and retrieve the clot. So what are its indications? It is indicated for any case of acute ischemic stroke where patient has presented within 6 hours of the onset of symptoms, or we can do up to 6 to 24 hours. I will tell you what these differences actually stand for. You may say, sir, we can say that up to 24 hours we can do, then why you are splitting it into within 6 hours or 6 to 24 hours? There are some points to learn here. If patient has presented within 6 hours, there is no need for an additional step, because within 6 hours you will still have some amount of viable brain tissue which I can save. 6 to 24 hours, I have to understand whether there is a tissue which can be saved or all of the area is dead. So if there is a tissue which can be saved, then it is worth doing it. If all of the area is dead, then it is not worth doing it. So how do I understand that? I can understand whether there is a savable tissue or not by doing MRI perfusion scan. MRI perfusion scan. So we will see if there is any area of the brain which is not perfused but not infarcted. Means what? That is talking about penumbra. There is an area which is not getting blood supply and it is infarcted. So that is dead, simple. But there is also an area which is not getting blood supply, but it is not looking like an infarct. That is our penumbra. So if penumbra is still there, then we can do the mechanical thrombectomy up to 24 hours. But if patient is presented within 6 hours, there will definitely be some amount of brain tissue which can be saved. You can go ahead and do the mechanical thrombectomy. You don't need to do an MRI perfusion scan to decide कि करना है या नहीं. Lalit Khan Chaurasi, I will address your point at the end. Okay. Now, any ischemic stroke patient who has presented within 6 hours or he has presented 6 to 24 hours after the onset of symptoms and there is a savable tissue on the MRI perfusion scan, we can think of mechanical thrombectomy provided there is a large vessel. This is the most important point here. Now, what do I mean by large vessel occlusion? Remember, I told you a story. I had asked this question to my senior resident during my undergraduate days. Why don't we do angioplasty for the brain? He had asked me to go out of the ward because I was irritating him. And he was logical back then because it was difficult for us to navigate a wire into the brain blood vessels and retrieve a clot. Technology has advanced, so now we are able to put a wire into the blood vessels in the brain, but still we have limitations. Our wire can reach in internal carotid artery. If there is a block in the internal carotid artery, I can do it. Or if there is a block in anterior cerebral artery, proximal portion, I can do it. Or if there is a block in the MCA, if you remember from anatomy, middle cerebral artery is divided into different segments. First proximal segment is called as M1, after that M2, M3 and M4. So if there is a block in the M1 segment, our wire can reach and we can retrieve the clot from there. If there is a block in the M2 segment of MCA or M3 segment or a distal portion of anterior cerebral artery, our wire today cannot reach. So in such cases, we cannot do. So these locations will be counted as large blood vessels. Internal carotid artery, proximal portion of ACA and the M1 segment of MCA. Okay. So most important thing you have to remember is any patient with ischemic stroke presenting within 6 hours or 6 to 24 hours with a savable tissue on the brain. If he has an occlusion in any of these blood vessels, we should think of mechanical thrombectomy. There are some additional parameters which are not important for an undergraduate student. Basically, we will not do mechanical thrombectomy for mild cases of stroke. So that is why we have a stroke severity scale on clinical grounds called as NIHS, and a stroke severity scale on the CT scan called as aspects. So both should be more than 6. If you want to remember, it is pretty easy. All you have to think of when it comes to mechanical thrombectomy is think of 6, right? Presenting within 6 hours and scores more than 6. You can think of going for mechanical thrombectomy. Now, if patient does not meet these criteria, then he is not fit for mechanical thrombectomy. For example, patient is presented within 6 hours of the onset of stroke, but I get a block in the M2 segment of MCA or M3 segment of the MCA. He is not fit for mechanical thrombectomy. Then what is the choice remaining with me? I have to only think of thrombolysis, whether he is fit for thrombolysis. If he is fit for that, we will do that. If he is not fit for that also, then revascularization is not possible. We will shift our focus to the secondary prevention. Okay. So with this basics, let me give you a question and see if you can answer this question. Let us try. We will come back and answer this question, and I'm very sure that by the end of the session, you will be able to deal with most of the questions from the stroke. So look at this question and try answering. So here we have a 52-year-old who presented with ischemic stroke within 8 hours of symptom onset. CT angio had revealed occlusion of M2 segment of middle cerebral artery. What is the next best treatment? Nizam Ajmal, it's a very, very important point. So first thing is, I'm telling you repeatedly, right? Within how many hours of onset of symptoms? Many times what happens is when the stroke started, we don't see. Like sometimes the stroke is witnessed, like, okay, the family member was having food with every other family member on the dining table, and then suddenly he developed the weakness. It has been witnessed. So exactly we know when the stroke started. But many times we don't know because the patient may be having aphasia, he may not be able to express when the problem started. In such cases, what we have to decide, like the duration is decided by simple factor. When was he last seen normal? We will presume that the stroke started then. For example, if someone was seen normal before going to bed and next day morning when family members go to wake him up and he is having hemiplegia, then we would presume that he was last seen normal before going to bed, maybe at 9 p.m., 10 p.m. That time the stroke happened. The stroke will be presumed to have happened when he was last seen normal. So when we don't know when stroke started, this is the method we follow. Right. So first point, easy fit for mechanical thrombectomy. To be fit for mechanical thrombectomy, patient should present up to 24 hours is fine, right? If he is presented within 6 hours, then I don't need the MRI perfusion scan. If it is 6 to 24 hours, I need the MRI perfusion scan provided he also meets other indications, right? What is the other indication? There should be a large vessel occlusion. That means internal carotid artery, proximal ACA or M1 segment of MCA. Here it is clearly mentioned that the CT angio revealed that block is in the M2 segment of MCA. So he is not fit for mechanical thrombectomy. Then we have to decide, is the candidate fit for the thrombolysis? I think all of you know the basic time frame for thrombolysis, right? Up to what time we can do thrombolysis? When patient presents within 4.5 hours of the onset of symptom. This patient has crossed that time limit also. So is neither fit for mechanical thrombectomy nor fit for thrombolysis. So revascularization is not possible for this patient. So what is left now? We can only prevent future occurrence of stroke with the secondary prevention. Okay, we'll come back again to this question after going further. To give you a summary, what we have understood so far, mechanical thrombectomy is indicated in any patient presenting within 6 hours of onset of symptoms or up to 6 to 24 hours of the onset of symptoms, provided there is a savable tissue on the visible on the MRI perfusion scan. Patient should have a occlusion of a large vessel where our wire can reach. Our wires can currently reach internal carotid artery, proximal ACA and M1 segment of MCA. And if you want to take it further details into account, then clinical severity of the stroke should be high, score more than or equal to 6, as well as radiological severity of the stroke should be high, score more than or equal to 6. Not important for the undergraduate student as well. Okay. Those patients where mechanical thrombectomy is not possible, what are the best alternatives we have? After mechanical thrombectomy, the next best possible treatment that we can offer is resolving the clot by giving the medications like alteplase, retiplase, or tenecteplase. We call it as thrombolysis. What are its indications? Patient should be a case of ischemic stroke, presenting within 4.5 hours of onset of symptoms. Within 4.5 hours of onset of symptoms. Okay. Second important point here is there are certain contraindications here. There are certain contraindications. Mechanical thrombectomy, there are no major contraindications, but for the thrombolysis, there are. The first contraindication that you should know is about the stroke involving more than one third of MCA territory. If there is a large stroke, thrombolysis is considered risky. Why? Because that infarcted area, bleeding can happen into it. So there is a risk of developing. You start with an ischemic stroke, you give thrombolytic agents, and then you bleed into the brain. So that becomes much more complex. So if the infarcted region is very large, more than one third of MCA territory, it is contraindicated. Second, there is contraindication if there is a recent myocardial infarction. Again, the reason for contraindication is wherever you have myocardial infarction, there's a possibility of hemorrhage into that infarcted area. Then third, if the BP of the patient is more than 185 by 110 despite treatment, it is contraindicated. Okay. Then fourth, it is contraindicated in anyone who is less than 18 years of age. Less than 18 years of age. Here, two important points which are used in MCQs is the BP at presentation. Okay. And stroke involving more than one third of the MCA. If you look at these contraindications, what do we learn? Most importantly, we are trying to prevent a hemorrhagic complication. Right? When BP is high, if I give a thrombolytic agent, patient may bleed profusely in the brain. If there is recent MI, the site of infarction, there may be bleeding. If there is large infarct in the brain, if I give thrombolytics, there may be bleeding. Right? So another possibility is when we have recent major surgery, the surgical site, there may be bleeding. That becomes a contraindication. If you're thinking why less than 18 years is a contraindication, the simple reason is the reasons for stroke in individual less than 18 are different from the reasons for stroke in adults. So under 18, you have diseases like vasculitis, moya disease. They become the reason for stroke. It is not because of an embolic occlusion or an atheromatous occlusion. And that is why thrombolysis makes no sense in those cases. Okay. So if you have to decide about thrombolysis, first thing you have to see whether patient is presented in time and there should be no contraindications. Then you can go ahead with the thrombolysis. So what is going to be our approach? So therefore I will address it. I will address it again. Okay. What is going to be our approach? Anytime you have a patient with stroke, you have to think, is he fit for mechanical thrombectomy? Is he fit for thrombolysis? If he is fit, we will go ahead and do that. If he is not fit, then we will go ahead with the secondary prevention. Now, for us to be able to understand the flow of process, there is a simple algorithm from the American Heart Association. If you remember this algorithm, all the questions about decision making, you will be able to get it right. What we need to do when we get a patient with stroke, first thing we will do is the non-contrast CT, right? As you know, that is the investigation of choice that will help us to differentiate whether it is hemorrhagic stroke or ischemic stroke. Okay. If it is ischemic stroke and if the onset of symptoms is within 4.5 hours, we will go ahead and do the thrombolysis if no contraindications for lysis. I've just give you the list of contraindications for thrombolysis. We'll go ahead and do the thrombolysis. But the story doesn't end here because thrombolysis is not the best treatment. What is the best treatment? Mechanical thrombectomy. We do not want to waste the time. That is why we will go ahead and do the thrombolysis. But after that, we will also get the CT angiogram. Why CT angiogram? Because our non-contrast CT will only tell whether there is bleed present or not, right? It is not good for identification of infarction and blood vessel occlusion. That is why we have to do a CT angiogram. Once the CT angiogram is done, if it shows that there is a large vessel occlusion, I have already told you what counts as large vessel. Internal carotid artery, proximal part of the ACA, and the M1 segment of MCA. We count them as large vessel. So if there is a block, then we have to see whether we should also consider mechanical thrombectomy or not. And patients who presented after 4.5 hours, obviously, for them, thrombolysis is not possible. Only thing that we can think of is mechanical thrombectomy. Obviously, to decide whether he is fit for mechanical thrombectomy or not, we have to do large vessel occlusion analysis using the CT angiogram. Once we have done that, if there is a large vessel occlusion and patient has presented within 6 hours, as I've already told you, there is no need for any advanced imaging. Go ahead and do the mechanical thrombectomy. If the patient is presented 6 to 24 hours after the onset of symptoms, then we have to do the MRI perfusion scan. If MRI perfusion scan tells that there is some tissue which we can save, then we go ahead and do the mechanical thrombectomy. If there is no tissue which can be saved, all the tissue is dead, then we can't do mechanical thrombectomy, right? This is the approach. So please go through this flowchart again once the note is shared with you, and then try solving more MCQs from the QBank or the apps. That will help you to consolidate one possible marks from this topic. What we will do is we will take up one or two more questions and we will see if we have got the flow right. So here is the question number 1. A 6-year-old presented with right hemiplegia and Broca's aphasia 5 hours after the onset of symptoms. CT on arrival, obviously we will be doing non-contrast CT, which should show no bleed. So now we know that this is an ischemic stroke, right? From this, we can understand that this is a question of ischemic stroke. Now let us read further. What is the next best step in the management? Okay. So now tell me, you have choices like thrombolysis, mechanical thrombectomy, CT angio, and MRI perfusion. What will be your next best step? So what did we learn? Please try to understand the flow of thought process. Patient presents with stroke. At the time of presentation, I don't know ischemic or hemorrhagic. This doubt will be solved by non-contrast CT. That is my first step. I get a non-contrast CT. If I get bleed, it is hemorrhagic stroke. If I don't get bleed, ischemic stroke. Once that is done, if it is ischemic stroke, now I have to think thrombolysis करना है या नहीं, mechanical thrombectomy करना है या नहीं. Thrombolysis के लिए what is the point? Patient should have presented within 4.5 hours of the onset of symptoms and there should be no contraindication. So can I do thrombolysis in this case? Can I do thrombolysis in this case? Obviously, he has presented after 4.5 hours. So thrombolysis is out. We cannot consider thrombolysis in this case. Okay. Next step. Next step is mechanical thrombectomy. Can we do mechanical thrombectomy? In terms of time frame, see, remember, what are the indications I told you for mechanical thrombectomy? For mechanical thrombectomy, patient should have presented within 6 hours or up to 24 hours. If he has presented within 6 hours, only additional indication, only additional parameter I need to ensure is there should be a block in the large vessel where my wire can reach. If there is a block in a vessel where my wire cannot reach, I can't do it. That's simple. And if it's presented after 6 hours, then I have to decide whether there is still some amount of brain which I can save or all the tissue is dead. If all the area supplied by a particular blood vessel is dead, then there is no point in doing the mechanical thrombectomy. So if they are presented after 6 hours, I need a perfusion scan. Within 6 hours, I don't need a perfusion scan, right? So now look at that basic and try to answer this question. What should be the answer here? Like you guys are getting the flow of thought. Patient presents with stroke. First question is ischemic or hemorrhagic. For that, non-contrast CT. Once that is done, if it is ischemic, I have two treatments available: thrombolysis and mechanical thrombectomy. Right? As long as patient is presented within 4.5 hours and it is ischemic stroke and there are no contraindications, we will definitely do thrombolysis. Apart from thrombolysis, I have to decide whether I need to do mechanical thrombectomy or not, because that is the best treatment. For mechanical thrombectomy, patient should have a occlusion in the large vessels. There should be an occlusion in the large vessel. So now this patient thrombolysis तो नहीं कर सकते हैं. Mechanical thrombectomy I have to decide. Within 6 hours, definitely I don't need a MRI perfusion scan. That is not required. MRI perfusion scan is only required if patient presents 6 to 24 hours later. But have I met all the indications for mechanical thrombectomy? Within 6 hours, large vessel occlusion, right? Now, how do I get to know whether there is large vessel occlusion or not? Only when we do a CT angio, right? So the here ideal next step will be to go ahead with the CT angio. If the CT angio shows that there is a large vessel occlusion, then the case becomes fit for mechanical thrombectomy, right? So please go through this flowchart one more time. When we have a patient with stroke, step number 1, non-contrast CT, bleed present, hemorrhagic stroke, different story. Bleed not present, ischemic stroke, right? Ischemic stroke patient, whoever, like if they are presented within 4.5 hours, if there are no contraindication, definitely we are doing thrombolysis, right? Apart from thrombolysis, we are also going to do the CT angio. And those who are presented after 4.5 hours, definitely they are not fit for thrombolysis, only fit for mechanical thrombectomy. There also we have to decide whether there is an occlusion in the large vessel. So CT angiogram becomes the bedrock of investigation after normal CT scan in any patient with ischemic stroke for first 24 hours. Because that will tell me whether there is a large vessel occlusion or not. And whoever has a large vessel occlusion becomes an eligible candidate for the mechanical thrombectomy. If they are presented within 6 hours, then directly go ahead and do a mechanical thrombectomy. If they are presented 6 to 24 hours later, we have to consider MRI perfusion scan to see if there is savable tissue, right? We will take up one or two more questions. Hopefully, with that, you will be able to get the essence of our discussion. So here we have a 48-year-old who presented with ischemic stroke 10 hours after, okay, let me change it, 2 hours after onset of symptoms. His BP at presentation is 220 by 100 millimeters of mercury. Okay. No contraindications for thrombolysis. Okay, I shouldn't say that. Let us say, how do you get it? What is the next best step? What is the next best step in the management? Okay, so one of the option I have is to go ahead with the CT angiogram, B, MRI perfusion scan, C, I have to start him on IV labetalol, and D, I have to start him on oral nifedipine. So let me see if you can get this answer right. What do you think should be the answer here? We have a simple flow, right? 48-year-old presented with ischemic stroke, मतलब non-contrast CT में bleed नहीं है. He has presented 2 hours after the onset of symptoms. His BP at presentation is 220 by 110. What is the next best step in the management? Okay, so as usual, the flow of thought is very simple. Any case of ischemic stroke, first see if he is right candidate for thrombolysis. If he is right candidate for thrombolysis, go ahead and thrombolyze. And then after the thrombolysis is done, assess for the large vessel occlusion with the CT angio as long as they are presented within 24 hours. If there is a large vessel occlusion and if there is a savable tissue, go ahead and do the mechanical thrombectomy. Well, do you think this patient is fit for thrombolysis right away? Is this patient fit for thrombolysis right away? What are the indications? Patient should present within 4.5 hours of the onset of ischemic stroke, and there should be no contraindication. Is there any contraindication in this patient's story? Yes, there is a contraindication. What is a contraindication? Yes, you are getting a BP of 220 by 100, right? As I have already mentioned, when BP is more than 185 by 110, it becomes a contraindication. So now tell me, what is the next step you would be thinking of in this question? Nuseba Abrak, absolutely right. BP emerges as a contraindication. So maybe like now we will be thinking the next step would be thrombolysis is totally out and let us focus on mechanical thrombectomy. No. If you go back to the contraindications, I mentioned the point here. BP more than 185 by 110 despite treatment. Nobody is stopping you from lowering the BP to less than 185 by 110. Agar, right, patient is presented 2 hours after the onset of symptoms. If you can lower, you have till 2.5 hours time to lower his BP. If before crossing 4.5 hours of the onset of symptoms, if you can get the BP back to less than 185 by 110, you can definitely go ahead and do the thrombolysis, right? So in that case, now what should be our answer? So here the next logical step is to lower the BP, do the thrombolysis, then do the CT angio, and agar CT angio में large vessel occlusion दिखता है, so then do the mechanical thrombectomy. So next immediate best step would be to go ahead and give IV labetalol. So please remember, BP more than 185 by 110 despite treatment is a contraindication, not just because it is more than 185 by 110. So here next step is to give IV labetalol. Same question, I mentioned that IV labetalol has lowered the BP to less than 185 by 110 at 3 hours. And then what is the next step? The next step is to do the thrombolysis. Okay. Now one last question for today. A 50-year-old presented with acute ischemic stroke 3 hours after onset of symptoms. BP at presentation or on arrival is 160 by 100 millimeters of mercury. Which of the following steps are necessary in this patient management? Okay, so option A, thrombolysis. Option B, CT angiogram. Option C, MRI perfusion scan. Option D, secondary prevention. Okay, so in this question, we will have multiple correct answers. So choose what all comes as correct answer. What all comes as correct answer. He is presented 3 hours after the onset of symptoms. His BP is 160, 100. Which of the following steps are necessary for this patient's management? So rule number 1. Has he presented within 4.5 hours? Yes. Should I think of thrombolysis? Are there any contraindication? बीपी वाइज तो कॉन्ट्राइंडिकेशन नहीं है. अगर कोई और कॉन्ट्राइंडिकेशन होता तो बताते कि हाँ रिसेंटली एमआई हुआ है, रिसेंटली सर्जरी हुआ है. Nothing mentioned, so I would presume that there are no contraindication. So easy right for thrombolysis? Yes. Should I go ahead with thrombolysis? Yes. Should I stop at thrombolysis or should I think of mechanical thrombectomy? Again, I'm taking you back to the flow chart. You need to get the flow chart right. If I do thrombolysis, should I stop at that or should I think of mechanical thrombectomy? We do not stop at thrombolysis. Thrombolysis ke baad, we do the CT angio to decide whether I need mechanical thrombectomy or not. If large vessel occlusion is there, definitely I will go ahead and do the mechanical thrombectomy, right? So then, do I need the CT angio in this question? Do I need the CT angio? Yes. ओके, अब सीटी एंजियो इतना बताएगा कि लार्ज वेसल ऑक्लूजन है या नहीं. अगर लार्ज वेसल ऑक्लूजन है तो ही इज अ कैंडिडेट फॉर मैकेनिकल थ्रोम्बेक्टमी. नाउ इन दिस सिनेरियो, इन दिस क्वेश्चन सिनेरियो, विल आई नीड द एमआरआई परफ्यूजन स्कैन? जब हम मैकेनिकल थ्रोम्बेक्टमी करना चाहते हैं, व्हेन डू आई नीड द एमआरआई परफ्यूजन स्कैन? When do we need the MRI perfusion scan? When patient has presented 6 to 24 hours after the onset of symptoms. If within 6 hours, I do not need the MRI perfusion scan, क्योंकि हम ये मान के चल रहे हैं कि अगर 6 घंटे के पहले ही आए हैं तो कुछ ना कुछ पेनम्ब्रा बचा होगा जिसको हम सेव कर सकते हैं. 6 घंटे के बाद में आया है तो पता नहीं कि पेनम्ब्रा बचा है या पूरा इन्फाक्ट हो गया है. तो इसलिए डिफ्यूजन या MRI परफ्यूजन स्कैन जरूरी है. सो डू आई नीड MRI परफ्यूजन स्कैन हियर? नो. Do I need a secondary prevention? Yes, for any case of stroke, we would require the secondary prevention. For any case of stroke, we will require the secondary prevention. This is how we will approach the definitive management of stroke, right? So please memorize that flowchart and try solving more questions and you will get the essence of that. I will give you a few points about the secondary prevention before we sign off. Okay, now how can we do secondary prevention? Two factors are playing an important role in the stroke. One is development of atheromatous plaque, and then the atheromatous plaque getting injured, resulting in endothelial injury. And जब भी endothelial injury होता है तो platelets आके चिपक जाते हैं, what we call as platelet plug formation. So if I have to prevent this cycle from continuing to the point where a clot gets formed, then I have to reduce the chance of atherogenicity and also platelet plug formation. So that is why for secondary prevention, generally we treat with antiplatelets plus statins. Okay. Now the question is antiplatelets like aspirin, clopidogrel. तो एक ही देना है या दो देना है? So when we give only one antiplatelet, we call it as single antiplatelet therapy. When we give two, we call it as dual antiplatelet therapy. So what should we do in a patient with acute ischemic stroke? The answer is we start with dual antiplatelet therapy. 2, matlab aspirin plus clopidogrel. That is the most commonly used combination, aspirin plus clopidogrel. But studies have shown that if you extend it for a very prolonged period of time, there is a risk of bleeding. तो कितने दिन तक हम दो देंगे? For 21 days. For 21 days. After that, after 21 days, we switch to single antiplatelet therapy. We call it as SAPT or single antiplatelet therapy. आप या तो aspirin continue कर सकते हो or you can continue clopidogrel. Depending on patient factors, whichever is suitable, you can continue. Like if patient has got peptic ulcers or if patient has got gastritis, you can skip aspirin and you can continue with clopidogrel. Or if you are using other drugs which interact with CYP19, in that case you have to skip clopidogrel and you can continue with aspirin. Both are equally effective. You can choose one, whichever is ideal for the patient, you can continue. But first 21 days we give two agents. Now when it comes to statins, what statins we should choose? You are familiar with atorvastatin, rosuvastatin, pitavastatin, simvastatin. Which one we choose? Okay, the choice of statin is not important. What dose we start is important. So there is something called as high intensity dose or high intensity statins. What is a high intensity dose of a statin? That dose of a statin that can reduce your LDL cholesterol by more than 50%. So dose of statin that can reduce LDL cholesterol by more than or equal to 50%. That dose. If I have to give you an example, if I'm using atorvastatin, then it requires around 80 milligrams to 80 milligrams per day to reduce your LDL cholesterol by more than or equal to 50%. But I can achieve the same result with rosuvastatin if I'm using 40 milligrams. So that is how we make a choice. We have to use a high intensity dose. If I'm giving atorvastatin 80 milligrams per day, if I'm giving rosuvastatin 40 milligrams per day. Now, last question to address is, what is the role of anticoagulants or heparin in ischemic stroke management, including heparin in patients with ischemic stroke management, right? So please remember, there is no direct role, no direct role. If we're using it for DVT prevention, used as DVT prophylaxis, because patient may be bedridden for a prolonged period of time, and there is possibility that they will develop a deep vein thrombosis and that can lead to embolism and death. To prevent that, they can give them heparin or low molecular weight heparin, but in the management of stroke directly, it has no role. Antiplatelets have a role, statin has a role, thrombolytics have a role, mechanical thrombectomy has a role, right? So this is about the stroke management. Spend some time from the notes on this algorithm and try solving questions from the app, whatever app you are following. And if you're stuck on any question in the next class, please shoot it to me. I will try to address, so that by the end of the next class, you will have a fair idea of answering all the questions about the stroke management. So that's it from me today, guys. I'll be signing out. Let me see if I have missed any question. Okay, so that was Samantha, how mechanical thrombectomy is done. So what we do is, we can enter your carotid artery through any of your peripheral arteries or directly puncturing the carotid artery. Once we enter, we pass a wire. Okay, so that wire will have, there are different devices to retrieve the clot. Let me show if I have any image. Okay, yeah, I think I have an image to show you. This device is one of the devices which can be used for removal of clot. This device is called as Mercy Solitaire. There are so many such devices available. As you see this device, right? It has this small trap and a wire. So we advance this wire beyond the point where there is a clot, and then we pull it. So that is how we can retrieve the clot. We can retrieve the clot. There are other devices which can break the clot. There are devices which can deliver a clot dissolving medication and then suck it out. Basically, we just cannulate an artery, reach where is the clot, and with the help of medications, dissolve and suck it, or with the help of baskets or wires, pull it. That is how we retrieve the clot. This is just one example, one company which produces this device called as Mercy Solitaire. That is how we get the mechanical thrombectomy done. Essentially very similar to how we do angioplasty for the main difference is, in angioplasty, after the clot is removed, we put a stent there. In patients with the stroke, when we do mechanical thrombectomy, we don't put a, that is the main difference. And there we are calling it as angioplasty, here we are calling it as mechanical thrombectomy. The next session is scheduled on Monday, and it is about ischemic heart disease. But before that, I would address all of your questions on the stroke. After you solve the app-based questions, you can bring in if you're stuck at any point, or you have difficulties, or you're not able to get why that particular answer turns out to be right. I will address them, and then we will take up with the ischemic heart disease. See you guys. Till then, have a good time. Good night.